Peeps, welcome back. We're here for another Pulm PEEPs Pearls episode. These are supposed to be short form, just casual conversations between Monty and I about a topic in pulmonary critical care medicine. We try to keep them under 15 minutes. Our last one went over because we spent too much time having fun and socializing. So today we're going to dive right in. Monty, I hope everything's going well. We'll catch up after the episode. Today we're tackling a bread and butter pulmonary topic, equal part physiology, and then just practicality, like what you do at the bedside when somebody asks about this or in clinic when somebody asks. So we are going to be talking about airway clearance in non-CF bronchiectasis.
Yes, I think such an important topic as well, Furf. And I love that we're through these Pulm PEEPs Pearls. We're going to be going back and forth between ICU topics as well as pulmonary topics to really get you thinking about things. But right, non-CF bronchiectasis, chronic cough, lots of sputum production. If you've had a patient who could describe the color of their sputum or the change in sputum, I think you know what we're talking about. But how can we really help these patients? So supporting airway clearance isn't just a comfort measure, but it's really central to daily quality care for these patients. So that's why we picked this topic for today. So we're going to go ahead and start with a brief case to ground us all. So we'll have a 58-year-old patient with a daily productive cough and a new diagnosis of non-CF bronchiectasis after recurrent infections, including several with Pseudomonas. She's seen you in clinic. She said she's heard about airway clearance, but she's overwhelmed by all of the potential devices and tools that she can use. So she's asking, Furf, what actually works and how do I choose what I'm going to do on a day-to-day basis?
Yeah, absolutely. And this is the perfect question, right? I think we think that, or patients often think that antibiotics are going to be the solution for this. The reality is clearing out those airways and getting some of that mucus out before you can have recurrent exacerbations or infections is just paramount to their type of care. But this patient is totally right. There are lots of gadgets. It can be overwhelming. So let's walk through some of the evidence and tools and how we tailor them. For just a brief background on this, non-CF bronchiectasis is chronic airway disease, marked irreversible dilated bronchi, and impaired mucociliary clearance that leads to this cycle of not being able to clear mucus, infection, and inflammation. Monty, you must see a bunch of this. I know you see it primary CF, but I'm sure you also get a lot of non-CF bronchiectasis as well.
Absolutely, Furf. Yeah, and it just actually coming back from the chest conference not too long ago, there was a whole session where I got to help moderate where so many people are thinking about this topic. And one of the trainee presenters was actually saying how the study that they looked at nationally, the incidence as well as prevalence of non-CF bronchiectasis is increasing pretty dramatically. And, prognosis of this disease not only depends on the etiology for the non-CF bronchiectasis, but really on exacerbation frequency. So things that we want to do are to try to help limit exacerbations and really try to preserve day-to-day health. So when we think about the pathophysiology behind this, as we all know, that cycle of infection, inflammation, insult, the sputum retention fuels this cycle, and it really ends up with neutrophilic inflammation, which damages airways and then leads to worsening clearance.
Yeah, I think there's been a lot of study into the quality of mucus, into some of the genes behind production of mucus that show us that mucus is not just this harmless thing that builds up in the airways. It actually can become impacted, a hotbed for infection, but also really inflammatory, promotes a lot of inflammatory cells and cytokines that end up damaging the airways and then making the clearance even worse. So we want to be able to use airway clearance techniques to be able to get this mucus out. So let's just go through some of the main families that we'll think about or talk about with our patients for airway clearance. So first we have breathing-based techniques. So this is for active cycle of breathing techniques that break the clearance into 3 different steps. So you basically have patients who are doing gentle breathing, then deep inspiratory holds, and then puffs and huffs to push the secretions up. This is the type of technique that is mimicked when we use positive airway pressure to generate a cough. It's basically that you're doing normal breathing, you're trying to get air behind, then generate a lot of positive intrathoracic pressure to lead to positive airway pressure and push the secretions outward. It's flexible, it's device free, it can be done anywhere. And so if this works, this is a really helpful technique for patients to be able to try to do focused a couple times a day to remove some of the mucus.
Absolutely, Furf. And another potential option, it's what's called autogenic drainage. So this is an exercise or a mechanism that actually uses controlled breathing at different lung volumes to help mobilize mucus in different airway zones. So this, like active cycle breathing, is going to take some coaching and some training, but can really be effective once someone feels comfortable doing this. And really going to shout out our physical therapists. I know this may be institution variable on who helps, but physical therapists are definitely trained in being able to do this well and can work with patients not only in the inpatient setting, but the outpatient setting to make sure that patients are comfortable doing these types of techniques.
Yeah, absolutely. I think that these techniques are great. They're great to have. I think you really do need very focused and experienced respiratory therapists, physical therapists to teach people about this. I think often patients are not able to do these on their own in an effective manner. And so that's when we get to adding some devices that might end up helping them have a little bit better clearance. So these are positive expiratory pressure devices or PEP devices primarily that we end up prescribing to these patients.
Yeah, for these PEP devices, so they can be mask or mouthpieces, really work by creating back pressure to keep the small airways open during exhalation. The great thing is patients can combine these devices with huffing or coughing with a bug to really have a multi-pronged approach to really help with clearance overall. But Furf, I know that there's so many other devices, like you think of Flutter, Acapella. What else is out there?
Yeah, these are, and honestly, when I'm doing this with my patients, I use an acapella most commonly that I prescribe. Aerobica is another one. I usually honestly look at Amazon with them to show them what the different devices are, and then YouTube to show them videos. Lots of resources out there, and try to see which device I can get from their local pharmacy or through their insurance. But the idea behind most of these devices is that inhalation is just your own to bring air into your airways. On expiration, the device is using some sort of valve or internal mechanism to add vibrations that are supposed to, through that expiratory phase, break up and vibrate to loosen that mucus so that then they can cough and breathe it out. And so most of the devices you can inhale without any resistance. And then when you expire, it has this sort of vibratory technique that hopefully will end up loosening that very thick mucus deep in the airways. They're small, they're portable. You can use them multiple times. You do have to clean them, but it helps add to that ability to do airway clearance multiple times a day, like we recommend, and anywhere for convenience of the patient.
Yeah, so great that they're portable. Patients could take them with them if they're traveling. So that's really helpful. I do also want to talk about, though, we talked about breathing techniques, these PEP devices, but other devices that we should be able to think about are what we call, like you may hear of the vest, or patients may ask you, like say they know someone with CF or non-CF bronchiectasis and they have a vest, and there's portable vests now. When you think of the vest, it's really a device to help with high frequency chest squall auscultation. Most patients will use it 2 to 3 times a day. It's external, it vibrates the chest wall, and it works well for patients with large amounts of sputum volumes. But I will say that you have to make sure that the patient wants this. There's some paperwork that has to go in to get these vests approved. But patients do like them. They have advanced so much in the last years. Usually you'd have to sit down, plug in the vest to an outlet, and you'd have to be at home in order to do this. Just like some of the Acapella or the Aerobica Furf, these vests are now portable, and patients can take them with them if they're traveling as well. In addition to the vests, though, Furf, what about just back to the basics, manual techniques? Have you ever recommended that, or any of your patients do that?
Yeah. I'll say most of the vest and even the old school techniques that come from the CF community are still out there and options for this non-CF community of patients who have bronchiectasis. I personally have not had a lot of patients who find huge benefits from them. I have one patient with non-CF bronchiectasis who has a vest and likes it a lot. And this we'll get into in just a second about how do you choose the right technique for this. But you can definitely, if the vest is too uncomfortable or if it's not a possibility, a caregiver or someone who helps the patient can do manual percussion and mimic the exact same thing that the vest will do for them. That kind of gets into, though, we have these options. How do we choose the right one for our patients? Monty, how do we talk to them about it? Which approach do you take in choosing through these different techniques?
Right. And there's not a one size fits all here, right? We're going to have to think about the patient in front of us, patient's sputum burden, strength, coordination, other comorbidities. what kind of lifestyle do they have, and really make an individualized decision with the patient. So sometimes I may initially start with doing the breathing techniques, as we mentioned, and doing something like an acapella or aerobica, because they can combine those two types of techniques before going all the way to the vest. But things that you want to think about or questions you should be asking as you're choosing the right technique are, can the patient self-administer the technique or the device themselves? What is the likelihood of adherence? So doing or creating a airway clearance technique, rotation or regimen with them that they're going to be able to do on a day-to-day basis is going to be so important. You want to think about other physical or cognitive limitations that may prevent them from using certain devices. Obviously, you want to pick a regimen that's going to be cost-effective. And then lastly, will they have support from friends and families in their household? And do they have the ability to get trained and coached by a physical therapist or yourself in clinic and really understand the mechanisms? That's how I think. If anything else you want to add?
No, I think those are all the right things in the conversation. The most important thing is if it's working. And so I feel like when I'm talking to patients, we talk about these techniques, and then sometimes they come in and they tell me, oh, I do the acapella 4 or 5 times a day. I don't bring up anything. And I say, well, then let's not do that. Let's stop, right? Like, this is not a lifetime contract that you're in, that you have to do it over and over. The idea is we need to figure out a way to mobilize this mucus, and we'll figure out what's right for you. I have one patient who says that honestly, the best thing for him is sitting in the bathroom after the shower with hot steam coming in and then using his acapella. And I said, great, why don't we try 2 showers a day and see if you can clear that way? So it's really about the actual sputum production and assessing the efficacy of it. But these are all great considerations and conversations to have, but we're in medicine here. We should talk about the evidence, right? So we want to talk about what papers we have out there that test these ideas and show how efficacious these different techniques are. Monty, let's dive into that.
I know, Furf. Yeah, it's like, what does the data say? So RCTs show that airway clearance techniques definitely increase sputum clearance and often improve symptoms and activity tolerance. But Furf, any more details on that? I know that's a vague takeaway. What else do we?
Right. I'm doing it and I'm producing more mucus. In trying to use some of the more standard quality of life scores or cough questionnaires, it seems like there is improvement, some modest improvement with oscillatory positive expiratory pressure devices and vest therapy. And so that's, I think, probably why my practice of using an acapella or a PEP up front, it sort of comes into play. You talk about spirometry. Spirometry changes are pretty limited, but it does seem like there may be some short-term FEV1 improvements in vest studies, but really this is a pretty limited metric that we have here. And then one of the big ones that we talk about are exacerbation. This is what we're trying to prevent. And I would say that exacerbation data is pretty mixed. Older trials were pretty small, not that many patients, pretty short. There was a recent RCT of some gravity-assisted breathing techniques that showed fewer exacerbations after 12 months compared to placebo exercises. But there's not a ton that says these definitely work to alleviate exacerbations.
Awesome for Friday. I think airway clearance techniques safe across most studies, very rare adverse events, but we do need to be thoughtful of any special patient populations. So I wanted to just highlight that before we end for the day. So for patients with you're concerned for fragile airways or a fragile patient themselves or a recent history of hemoptysis, you definitely want to start gently. So you may just want to start with breathing exercises, and if everything's okay, no evidence of hemoptysis, then you may want to start in acapella or aerobica in the next 24 to 48 hours. For those with severe obstruction or early airway collapse, we can think of PEP or oscillatory PEP can help keep those small airways open during exhalation, so that could serve dual purposes. And then I think we have to just be mindful if our patients have any mobility or coordination limitations or barriers. So we may think that the chest or oscillatory PEP devices, are they going to be appropriate for those patients? Definitely they could be. It could still be doable, specifically if someone has high sputum production, but we want to just be mindful when we're talking with our patients about that. Anything else before we end our time today?
No. I think we've gone through it as well as we can. We will talk separately about medications and airway clearance. We'll talk separately about preventing aspiration and airway clearance in patients without bronchiectasis, but this is what we wanted to cover for today. So to summarize and take our take-home pearls, we'll start simple, use some breathing techniques, and generally add on a positive expiratory pressure device. pretty close to upfront if those breathing techniques are not adequate for sputum clearance. Consistency is what matters the most. We know that from some of these studies, the benefits are clearest for patients who are doing it and who actually have good mucus clearance. There's no universal best airway clearance technique, so we have to use the one that works best for your patient. And the ERS guidelines are clear that we have to individualize, reassess, and educate our patients on this. And safety overall is excellent. Keep in mind some of the things Monty said about patients who have potentially a history of hemoptysis or small airways disease and how that might impact your selection. All right. Thank you guys for tuning in to Pulm PEEPs Pearls. You'll join us next time. Monty, I can't wait to talk about our next topic.
I know. See you next time, everyone.